Okay, pnawn da everybody. Welcome to the sixth, I think, in a series of public accountability meetings. So Professor Neil, Phil and everybody else. We have a section of the Welsh Government Health and Social Care team here. You have a selection of board members with you, Neil. There's a lot of people in the room, but rather than go around the table, we've got some name tags, but for the benefit of people watching, we can introduce ourselves the first time we speak, if that's okay, so people know who's contributing. The meeting is being live streamed, and there'll be people watching who have an interest in the discussion that we have. We have translation facilities available, so please feel free to contribute in Welsh or English as you prefer. In advance of the meeting, the Health Board has sent a detailed evidence pack, for which thank you. There'll be four areas that we will cover in the discussion. Firstly, in relation to finance and planning, then questions to do with access to services, questions then to do with how the Health Board is adapting services for the future, and lastly, questions around how the NHS is being run, and in this context, how the Health Board is being run, so that the evidence pack covers each of those areas, and in a number of them has given us good levels of assurance. So the focus in this discussion will be those areas where we're looking for more assurance. So it may seem to some, because of the conversation focuses on challenges more than successes, but that's in a sense the inherent in what we're in the discussion. And there is obviously an opportunity for the board to set out its position as we approach each of those four areas. Some of the questions which I will ask are motivated by questions which have come up in correspondence from the public, so to reflect questions which the public may have. At the start of each of the four areas, there'll be an opportunity for somebody from the board to give a short introduction to how the board sees things. I would ask for that to be no more than 4 minutes, so that we have plenty of time to get into a good discussion on the issues. And I'll just let people know if we're looking like we're going over those 4 minutes, just to help keep things moving. Before we get into the four agenda items, Neil, do you want the opportunity to say a few words at the start?
Well, that's good, then, the cabinet. Thank you very much. That would be great. I'm not intending to hold court and just respond to each of the sessions. I've asked my colleagues to lead on each of those sessions as we go through the process. Thank you for bringing us together today. I think public accountability matters to the Health Board. I think it helps sharpen our focus. It strengthens the connection between us and our communities. And it makes us more answerable for the things we're doing well and the things we're not doing well. So I'm grateful for this opportunity. We don't think it's necessarily a pleasurable thing, but we think there's opportunity in here for us to learn lots of new things and to understand things differently. As the chair of the Health Board, I think the Health Board has enormous strengths, but I think it has also significant challenges, and those challenges around the rurality of the Health Board, a large landmass, probably one of the most biggest in Wales in terms of Health Board coverage, four hospital sites, all of which have decayed gracefully over the last 50 years, but which are now significantly problematic for us. I say this not as an excuse for where we are. I say it as an incentive for how we want things to be different in the future. So we use this as the basis for being able to plan how we deliver safe, quality, high-value services to patients in the population of West Wales. I think we've seen some success over the last 12 or 18 months. I mean, we've fortunately been de-escalated in a number of areas. I think we've improved in terms of our governance and our leadership, and I think some of our delivery around our cancer rates and services has improved correspondingly. I don't think we've got to the state we would anywhere like to be in relation to this. I don't think they're isolated successes. I think they show that when we apply ourselves and when we're focused and we have a stronger governance model and we're more answerable, that actually the organisation responds. I think the challenge for the board is to make sure that it radiates its motives and its behaviours down into the organisation, as opposed to cast a shadow that everybody feels as if it's not part of their problem. So we want everybody to own this. Having said that, I think we're doing well in some areas. This is not a celebration. It's an honest stock take, and I'm hoping that's what will emerge during the course of this afternoon. We know urgent and emergency care remains fragile. It's an enormous challenge for us, as I'm sure you will want to pick up during the course of your questions. And we rely heavily on 2 clinicians delivering absolutely vital services in the area, and our diagnostic weights and our pathways of care are also problematic. And we continue to experience quite challenging flow and patient experience issues. But I think the pressures, although they're very real and very visible, they don't define us. What defines us is our ability to meet those pressures and to make a difference to what we think is happening in the future. I remember when I joined the health board, I was thinking, well, how do we want to be? And I want us to define ourselves in terms of the challenges we embrace and the things we're trying to do, not define ourselves as an apologist for services that are not good enough or not delivering well. And that's not an assurance that we will deliver all the things we need, but for me, it's a powerful motivator for wanting to make a difference and do things differently. And I think the board does that. Just to kind of put together, we're a stable board. So I think one of the really important things that's happened over the last 12 or 18 months is that we now have a full complement of executive officers. And although we lose one of our IMs at the end of this month, we have replaced her with an equally talented and clever IM. So I think it's really important to have a stable platform on which you try to plan and deliver these long-term changes. So I think that's all I want to say at the start.
Okay, thanks, Neil. And there'll be a number of responses that we'll pick up in our discussions over the next couple of hours. So let's turn first then to finance and planning. My officials have written to you very recently in relation to 2 elements, the risk element in relation to the cost of addressing the position for Band 2/3 workers. So that's had an effect on your forecast deficit. But who would like to set out the position from the board's point of view?
Great. Under this, Vice Chair, I don't know, bottom of the table. I don't know. I think we'll open up Cabinet Secretary, and then I think you will address some of the core questions.
Hello, Diolch Ysgrifennydd y Cabinet. Thank you very much for the opportunity to present this today. It's much appreciated. We've acknowledged for many years that the model in West Wales is unsustainable. The organisation has been in deficit since before the Health Board was formed, and we continue to deliver services under real workforce pressures, with clinical teams spread across 4 acute sites covering a quarter of the landmass of Wales. We want to shift the centre of gravity towards prevention, towards early intervention and strengthen primary and community services, supported by digital and new technologies, so that more people can remain well and in their own homes. We face constraints of one of the oldest and poorest committing states in Wales, and this limits our ability to consistently provide the standard expected of a modern health service. It was therefore right that we were placed into targeted intervention in February 2024, coincidentally the month I joined the board, hopefully not in cause. Since then, we have worked systematically through each area requiring improvement. We have made genuine progress. We've been fully de-escalated for CAMS and moved to enhanced monitoring for leadership and governance, planned care and cancer. But significant challenges remain, particularly in our financial position, urgent and emergency care, and the fragility of several core services. As part of our clinical services plan, we are taking a detailed and transparent look at 9 services. This is naturally emotive, but it is essential. Many of our services are highly fragile and dependent on a small number of clinicians. We've seen the consequences over several years when we fail to act early, which is why we are choosing to be honest with our staff and public and work with them to shape resilient, high-quality care in Mid and West Wales. Despite the challenges, we're incredibly fortunate. Our staff are committed, innovative, and deeply connected to their communities. This is the foundation on which we want to design a system for safe, sustainable, accessible and kind, and aligned with our mission of a healthier lives well lived. Turning into finance, we began the year with a planned £31.5 million deficit, which reduced to 30 million following discussion with Welsh Government on the affordability of some locally chosen investments, including parts of our prevention approach. We'll revisit this at the end of the year because we recognise its importance to our population, and the restated plan reflected the difficult starting point created by workforce pressures, demand growth and inflation. It included the expected costs of Band 2 and Band 3 transition and absorbed the uplift in employers' national insurance, and we are very grateful for the conversations and support from our government in that space. Throughout the year, we have kept a tight focus on control. I was going to talk about the Welsh Risk Board, but we're very grateful for recent conversations, so I won't stay talking about that, and we appreciate the help and support. We set a savings requirement of 46.4 million. The organisation has identified over 48 million savings and is forecasting 48.1 delivery. This is really encouraging, but much of it is non-recurrent, and we retain a recurring gap of £4.7 million a year against an opening plan. We are very clear as a board that the focus must now shift from short-term grip, which we have, to long-term sustainability. We agreed a financial roadmap to reach sustainable position by 27-28, and this remains our anchor. Cost pressures remain concentrated in well-known areas: medical agency, long-term mental health packages, rising negligence liabilities, but our response is more structured. We've strengthened fostering job planning, reduced nursing and agency to less than a quarter of its previous level, reduced medical agency and eliminated agency administration, clerical and healthcare support workers' use. The variation between the clinical care groups is now managed through integrated governance arrangements which bring finance, quality and performance together every month. The wider performance context is important. Urgent and emergency care performance has improved, with ambulance handovers over an hour almost halved. Cancer performance has strengthened, but we're not there yet. Workforce retention has improved, with notable reductions in turnover, especially in nursing. These shifts create the conditions for financial recovery. The pressures remain, particularly patterns of care delay and diagnostic waiting times, and these do translate into financial risk. Our programmes on flow, community capacity and discharge are therefore critical. In summary, and Cabinet Secretary, we are proud of the progress the organisation has made over the last year and grateful to colleagues across the Health Board. Our focus for the coming year is on systems transformation that delivers recurrent savings, sustainable workforce models and financial alignment with our clinical services team. As a board, we are united that this is the route to long-term stability. Diolch am fawr.
Two questions for me to kick this off, and I know it's Jacqueline and Helen will also come in on some detailed questions as well. So you've made a year improvement, as you were talking about in your introduction, and our assessment is that you should deliver the 22.1 target. Just want to understand the board's confidence around that, and then secondly, when we made available funding in December 2024, as you alluded to in your opening remarks, we were clear about the need for an improvement trajectory to deliver in-year balance by the third year. So some more detail on where that is, what your confidence level is, and what that might need to look like in practice.
Yeah. Okay. Hugh.
Diolch yn fawr, Cabinet. Hugh Thomas, Cyfarfod and Director of Finance. Just to provide assurance over your first question in terms of delivering a revised target control total, I think we recognise that it's still not good enough to be delivering a 22.1 million position, but I think we're reasonably assured now that we can achieve that, recognising performance to go and there are operational risks that are always being managed, but there are also operational opportunities. Our current run rate provides us with assurance that we can get to that 22.1 million revised position.
So you don't think you need to make any new choices in the rest of the year in order to deliver that? Is that?
There will be new choices that need to be made if some of the risks materialise. Yeah. So, but that's within the realms of operational management now. That will be. So I'm confident as I can be at this stage, recognising organises 4 months to go. If I just turn to the longer term picture for us, I think Eleanor and Chair have already alluded to some of the structural fragility challenges we have as an organisation, and they're currently certainly part of our thinking. I took to board at our last meeting in last month, on a paper on what our medium-term recovery trajectory will need to look like. We've been focusing this year largely on gaining assurance over this year's position, but now that we're reasonably assured of that, it allows us to turn our attention to some of the choices that we will need to make as part of that longer-term recovery trajectory. There is, I guess, if I summarise it, we have spent some time through the TI process understanding the cause of our problems, understanding the challenges we've got, and I think that the TI process has been really helpful, and work with and just P&I has been really helpful in helping us assimilate that understanding. And clearly, we've talked about medical staffing as being part of our challenge, partly driven by configuration issues, which require a broader response. But we're also very conscious that we are overly reliant on secondary care services to provide services, especially within the urgent emergency care system. And that, again, is something that we will be assessing as part of that medium-term recovery trajectory.
Just on that, do you think so that it's a 3-year trajectory, isn't it? So some of these choices are the moving of services into the community, and a long-standing policy aims for us all. And I think collectively, it's fair to say that we haven't made probably the speed of progress that we would have all have liked for lots of good, sometimes good, for not so good reasons. But that's, I think. So, what confidence would you have that over that 3-year period, you would be able to make those choices and therefore deliver the value for money that you're looking to do?
Yes, certainly in terms of making choices, we're already active discussion going on, active plans being developed in terms of bringing those choices to the board and to a conclusion. In terms of the impact that will have, naturally, I can't give you assurance at this point in time that is sufficient in and of itself to get us to a recurrent balanced position. And that's going to be the work now that we will be progressing over Q4. We have built a number of tools, though, that this year has given us confidence in cost control. I think that's really important to note. And it's given us and we've spent the year rolling out tools that will give us confidence in maintaining that cost control over the medium term. So I'm looking at systems like Allocate in terms of rostering our medical staffing in particular. We've already rolled out nurse staffing, bringing in rate cards, which have been an issue for us for quite some time, but also operational systems. So we've rolled out a flow system this year, and EOBS is coming next. That's releasing time to care. That's making sure we can gain a real accuracy and understanding of what the pinch points are in flow across our system. I think that's really important for us as we embed the changes in urgent and emergency care. But we want to become a value-driven organisation. I think that's fair to say. We've got expertise within Swansea University that we want to lean into through the Intensive Learning Academy, and how we bed that into an organisation that wants to become a value-managed system.
And how far do you feel you are away from that, would you say, at the moment?
So I think some of that is a cultural improvement programme that we're going through, and we've commissioned some work from Swansea to support us in embedding that thinking across the organisation.
Okay. What's pleasing in relation to that is it's clinically driven. Okay. So I think the signs are very positive because our clinicians are leading this case for more value-based healthcare and making the right choice that's both the balances cost against benefit.
So where would you say that's already happened?
It's already happening in
where would you say? Okay, yeah.
In Windbush Hospital, so it's being led by Karen Brown, one of our lead clinicians, and it's very much evidenced in her work. Okay. So I think that's starting to spread as a cultural standard across the wider organisation.
Okay, sure.
If I just conclude, the change process is a critical issue for us here, and we've demonstrated that we can do that in certain areas. Clinical services plan, I'm sure we'll come on to that, the key part of that. But also, as part of a digital transformation programme, we've demonstrated we can put change into our system. It's very difficult to manage status quo and the change, but we have got the tools now to deliver that.
Okay, thank you. Okay.
Thank you very much. And, good afternoon. I'm Jacqueline Totterdale. I'm the Director General of Health, Social Care and Early Years, and also the Chief Executive of NHS Wales. You're welcome. So, Hywel will probably ask you more of the technical questions, but mine really is about some of the things that you've mentioned in what you've just said. So, you often hear about pathways of care being a real issue, when actually, if we really look at our pathways through hospitals, there are actually a lot of things we can do in the hospital. So it's, that will both get the patient the first time, patient to the first time, to the right place first time. Second bit is about, so what is your relationship with social care? How are you working together in order to reduce issues within pathways of care? And the third bit is really about frailty. Because we know, and we're beginning to put a real focus on frailty across Wales at the moment. We know frailty aesthetics at the front door will stop a lot of older people coming in and therefore deconditioning. And we also know when we get older people and they do decondition, we don't try and recondition them. And all of that would actually be not only benefit to the local population, but actually a benefit to the bottom line because we're getting to people at the right time. So I just want to understand. So it's all that, it's all about being able to both, releasing time to care, getting our sisters to the right place first time, and as a result of that, the impact that will have on actually your finances.
Would you like to? We talked about this earlier, so let's pick up.
So maybe if I start, I know Andrew will come in, but this is I'm Phil Claude, the Chief Executive of Hywel University Health Board. This is a critical question for us, and we know we can't do this on our own. It has to be done in partnership. On your first question about the where the challenge lies, is it a social care problem or a health board problem? Well, actually, when we look at the stats broadly, 25% of it is just our issue. 50% of it is our issue and local authority, and maybe 25% of it is social care. So 75% of it is we have at least some part to play, and probably the dominant part to play. So we do own the issue with our local authorities. We've had some challenges on the point about the relationships with our local authorities. I think we have effective working relationships and good relationships with our local authorities. I think we would say, and I think our local authorities would say, we're still working on how we make those as effective as possible and as productive as possible, given the fact we do have those good relationships. I mean, we've had the challenges at Glangwili Hospital in the last 24 hours. I'm pleased to say we've recently stepped down our business continuity incident, but that's not something we do lightly. My response to that was to speak with the chief executive of the council. I was speaking to first thing this morning. I'm meeting her tomorrow morning first thing. So we have a very close relationship and understanding that this is a joint issue. On the last point on frailty and deconditioning, that is a core piece of our plan. It has been this year, but will be, in our discussions earlier, will be one of the key fundamental planks of our plan next year. But
can I just ask before you hand on to Andrew? So would you say that you have a clear sense as a board of what because this discussion is in the context of the budget and planning, would you say that you had a clear sense as a board of what the potentially adverse impact on your budget would be of not being able to make the progress that you want to be able to make in terms of discharge? Do you have a clear, are you able to quantify it? I'm not asking you to give me a figure now, but what's your level of granularity on that?
We have quantified it on a number of occasions. I know you've done that quantification, and it is significant given the number of people in our beds who wouldn't need to be there if there was some other option available. And that isn't just a social care issue, that's also that's a joint issue. So we own that. But when we have over 200 people in our hospital beds who wouldn't need to be there if something else was available, You know, that's something like about 25%, 30% of our bed capacity. That has a very significant impact on the operations of our hospital. So we're right, which is why we're rightly focusing on it. But it isn't what I wouldn't. I know the question's about that. I wouldn't say that that's our only focus, because there's a huge amount that's about efficiency and flow within the hospital, a huge amount that's about the kind of assessment that we're able to do at the front door, which we've talked about the challenges around that, and also the admission avoidance work that we also do with partners, GPs, WAST. So it's a whole system that leads us to having people in our hospital too long, and sometimes it's because we haven't taken preemptive enough action in the first place.
Okay. I mean, just to add to that, it is, you're absolutely right, Cabinet Secretary, it is an issue of finance and budget, but actually it's a terrible thing.
No, it's a completely terrible thing, but this part of the agenda is really focused on the budget. So it's clearly a terrible thing, but I want to understand.
I wasn't suggesting you didn't think it's terrible.
I want to understand what that means from a finance and planning perspective.
Yeah, of course.
Did you want to bring anybody else in hiring?
Just to respond to that challenge, Cabinet Secretary, I think we would recognise that there is an awful lot of patients who are being treated in the wrong place at the moment, and an awful lot in ED who shouldn't be in ED. If we were to quantify what providing a ward-based service to those patients would look like, it would be an extra £8 million on our cost base this year.
Okay.
If we were to quantify what disease prevalence and growth would look like without changing anything next year, it could be an extra £12 million on our cost base. So we have an understanding of what that could look like. The challenge, of course, is translating that into a value-based upstream investment. And we know that some of this cost is hidden within the system. It's a hidden deficits that we're managing.
Okay, thank you.
Yeah. So, Franza Jones, Director of Finance, cover the Cyhoeddus. But can I just say up front, recognise the position and points made, and also applaud the ambition on the greater prominence of value-based healthcare and being a value-managed system. We had a really constructive session on that recently, and I think you're really ambitious on that space, and we need to support that from a government perspective. So welcome that conversation continuing. So on the financial position, I think Phil and you would certainly recognise my challenge to you this year, that you've had challenges converting operational underspends into clear and recurring savings. If I look at your evidence pack, only 30% of your savings forecast this year is deemed to be recurrent. Historically, I'd say the health boards describe things as non-recurrent to then deliver them again the following year. And I think the nature of some of our interaction is we have more confidence in your ambition, we have more confidence in your ability to deliver an improved position than you show us. And then you deliver the improvement.
Yeah.
So my question is, what action are you taking to improve that position, to make those savings recurrent, to get a better underlying position? Because I think that's going to be critical for us from a confidence point of view.
Yes.
Perhaps if I start, so Phil Plor again, Chief Executive. I take your point about your confidence being higher than ours, and I think part of that issue might be the historical context of this organisation, that we have been an organisation that has had even more significant financial deficits and less confidence from Welsh Government. So I suppose that's partly why we've been perhaps more cautious than you'd expect over the last couple of years. It is problematic, of course, that we've got a large proportion of non-recurrent savings compared to recurrent, not just because that gives us a challenge into next year. It gives us a challenge around forecasting. But also, when you look at the non-recurrent savings, quite a lot of them are in areas where we would want to be allocating more resource, because they would be high value. So areas like population health, primary care, mental health, OD, those would be the areas where if we're safeguarding the future, we would want to be allocating more resources. There's an allocation issue here as well in the mix. So I suppose part of our one of our big strategic and practical challenges is how we switch that, and that's something as a board we're really engaged with.
I agree with your question, Luke, because it's a position the board takes, which is, this feels like it happens every year. So what's the thing stopping us from turning that into a recurrent saving? And I suspect, it's got to do with financial confidence and literacy across the organisation. I mean, I defer to the finance director. From my perspective, I think that's it.
Yeah, I agree with the comments quite naturally. If I just take it in a slightly different direction, we've had a period this year where financial discipline has been embedded within the operational teams within the organisation. We've got a new operational structure in place, and that has been maturing over the year, and I think we can see the benefit of that increasing maturity coming through this year. We have robust scrutiny. Lisa and I in particular have the pleasure of our weekly financial control group, where we review and scrutinise all of our recruitment activity, and that has resulted in us not recruiting a number of administrative roles across the organisation. That's been released on a non-recurrent basis this year. There is a choice for us as we go into next year now in converting that into a recurrent benefit. But we also recognise that those administrative roles were doing something, and that we need to have a more strategic way of substantiating that benefit as we go into next year. We've got a patient services centre conversation that we'll be bringing to board in terms of how do we interact better with our patients and professionalise that service while reducing the admin burden. So I think some of this is about how do we fix the baseline challenge that we're facing. But Phil is absolutely right that we've had a degree of underspending across executive teams this year, across public health and within dental services. Now, within dental services, that's not been deliberate, that's been fortuitous. We want to see people having their being treated, but that has resulted in a non-recurrent gain for us that we recognise that would need to be delivered in the future. So I think some of this comes back to the choices we will need to take between now and March as we build on next year's plan.
So you're currently at 30% an outlier. You're outlining the last context of 30%. I'm obviously going to say, why isn't it 100% by the end of March? So accepting all of that, I've got something about what in the next 4 months is going to turn the dial, because I understand it's choices through your planning process, but what specifically is going to make that 30% become a much higher number? Because we run into next year an expectation of an improvement trajectory that has to be a much bigger the proportion. There has to be that step change. So how are you going to do that in 4 months?
So let's start. Well, I suppose when we look, we've because of the stage we've got to with the delivery of our plan this year, and the sort of confidence of delivery around the financial and money performance elements, it has meant again that we'd be able to start planning at a relatively early stage for next year. So we're able to have a discussion, albeit brief because we're coming here, on our plan for next year this morning as a board. So we're starting to work through how we'll develop those choices of board. When you look at our the kind of savings plan that we will need to deliver for next year, I suspect there'll be a large element of efficiency and productivity, which will need to cover some of the inflationary costs. But there will be another element which will have to be some structural significant change. And within that, there are choices. For us, that's quite a challenge given our geography.
Yeah.
So we're always trying to balance the fact, access, travel, transport, because this is what we hear from the public. When changes are made. So I suppose we're really mindful, but when choices are brought to board of the communities we're serving and the difficulties they have sometimes in accessing services. So it's not going to be easy, but I think that we will bring those choices to board. Inevitably, the areas, there will be some areas that we are outliers in because of our geography. That there will be some outliers which naturally will come up as choices for us to have to consider.
Isabel.
Just a brief, sorry, Isabel Oliver, Chief Medical Officer. You mentioned that understand in dental had not been delivered, but you also mentioned understanding public health. Was that delivered? And if so, how does that fit with your introduction, highlighting the fact that you want to move towards prevention and you will need your public health team to help with that?
Thank you. It wasn't deliberate insofar as there wasn't a choice at the start of the year to ignore prevention to the benefit of the financial position. We have been working up, and our Director of Public Health has been working up our 24/7 model, which has taken some time to work up, and that will be operationalised and embedded. But it has been a fortuitous gain in some ways that we've benefited from this year to our financial position. We're hoping now that the evidence certainly suggests that the delivery of that new 24/7 model will result in benefits for us going into next year and the medium term.
Okay, thank you. We're going to move on now to the second area that we're going to discuss today, which is how the health board is seeking to improve access for all. So, for the team, there's a brief overview.
I'm asking Annalise to lead this.
Thank you. My name is Annalise. I'm an independent board member of the community. And so over the last year, we have improved access to timely care across many of our pathways and specialties. We've seen progress in cancer, family care, diagnostics, mental health, and even in our very stretched urgent and emergency care system, thanks to some exceptional efforts from our staff as well as support from Welsh Government. And while this progress is really positive and it gives us an indication of the impact we are able to deliver, we are absolutely clear that this progress is of little comfort to those patients who still wait too long to receive the help that they need when they need it. So we approach this discussion around access with that humility in mind and with an absolute commitment to improvement. So colleagues have already touched on the questions of sustainability for us from an internal perspective. That means that we need to think about how we shift from short-term solutions that have made difference, point of difference to access, to those longer-term sustainable measures that are necessary. The two key things workforce has already come up, of course, and that's not only in terms of pure numbers, but also the way we configure our workforce, which relates, of course, to the configuration of services, how we think about how we assemble skills into roles and ensure attractive career pathways for our colleagues. We know that any rural area will struggle to some extent with that. We've had lots of success with promoting our own region as a great place to work and live. We've done great work around growing our own, and Lisa, I'm sure, will say more about that. But right now, we have material gaps in our clinical capacity, for example, in our urgent and emergency care system, in therapies, in health sciences, and many more. And that means that patients are not consistently seeing the right people at the right time. And this has consequences for the patient and their family themselves, of course, but also for the way that we use capacity in the system. The second thing relates to infrastructure and equipment. We continue to make significant capital investments across our estate, but the reality is we work from an aged hospital estate, often using aged equipment, which is unreliable and disrupts access to care on a daily basis. And many of our most significant risks and consequences relate to those capital needs. So these challenges that we face internally are the need and urgency of agreeing a long-term strategic approach to service delivery, which itself must be considered from that wider perspective of population health. So I think we're pretty clear as a board that central to our success will be to improve consistency and reliability of access 7 days a week. And this will help and be helped by earlier access to care in the community, and Andrew, I'm sure, will elaborate on this later. But this will only be possible if we lean into those geographical configuration challenges that I mentioned earlier. The proposals that form part of the first phase of our clinical services plan move us solidly in that direction. And phase two will inevitably need to focus on urgent and emergency care pathways, which we know continue to be one of our top priorities. I think what is clear from our clinical services plan engagement thus far is that transport across our rural area is an enormous concern to patients and communities, and that working with partners to address this issue will be absolutely key, and we must, because the quality and safety consequences of preserving the status quo are just too great to settle for.
Okay.
Thank you very much.
Thank you, Becca. So, I've got some questions on urgent and emergency. Yeah, lung cancer. I know Jeremy will want to come in on planned care more broadly. So, there have been over the last number of months, there have been improvements in the speed of handover from ambulances to emergency department, which is welcome. It'd be keen to hear from you about sustainability and future progress in that space. But there are too many people who are waiting too long to get their clinical assessment, and there are too many people waiting more than 12 hours in urgent and emergency. So in the emergency department. So I'd like to understand what the board is doing about that, and what your assessment is of why the interventions that you have in place aren't yet getting you to where you want to be and where we want you to be as well.
Okay. In fact, we had a conversation with our clinical leads this morning on this thing, but I'm going to ask Andrew to respond to that. I'll come back at the end. Yeah.
Yes, thank you, Cabinet Secretary. Just for the Brothers Chief Operating Officer for the Health Board. I think it's right and important we have made progress over the last 12 months, but I think, as we've said, we recognise we're nowhere near where we would want to be. We have taken some really deliberate steps this year, just in Hugh talked earlier on about the operational structure. We've taken some really deliberate steps in how we restructure the organisation to align acute and community services under the same leadership team, which is enabling us to look at our urgent emergency care pathways and flow in a very different way. And also that provides a foundation for us to think now over Q4 around how we think about aligning our cluster model and our primary care teams into that arrangement, as well as part of thinking about community by default and community by design as a way forward, because we do have a really strong clinical consensus around the direction of travel and the vision we want for urgent emergency care. And it's very much an integrated urgent emergency care model delivered as close to people's home as is possible. We've had some, I think we've made progress. I think some of the fundamental challenges we've got that are preventing us going quicker, and we talked about some of these this morning, are some of our workforce challenges. So if you look at, for example, at some of our medical workforce challenge in our emergency departments, we've probably got about a third of the number of medical doctors and consultants that another similar sized or health board in Wales would have for a similar kind of configuration. That means that we lack some of the senior decision-making capability at the front door, and we know from the learning we've had over the last 12 months to 2 years that the more senior decision-making capacity we can front end, the better decisions we can make, the more admissions we can avoid, and the better we can stream patients into the right pathway.
Can I just ask you on that specifically? So if I was a member of the public who's completed your people experience survey, the main cause of dissatisfaction is in relation to waiting too long to get a clinical assessment. So it's pretty much top of the list of things that the public are telling you they basically want you to do something about. So where would you say in your priority list is getting the solution to address that? Mindful of the points you made, which I understand about recruitment challenges, where is that on the priority list, and what would you say if a member of the public is watching now, what are you going to say to them and the things which you're doing to address that specifically?
So I think I think it's one of the top 3 priorities for us is to understand how we can increase that capability of senior decision making at the front door to address those assessment delays. I think the second one would be around, we are very Monday to Friday focused at the moment in terms of our service delivery, and how do we enhance our 7-day cover and provision to keep people out of hospital. So that's through our enhancing the delivery of our clinical streaming hub to direct people into the right pathway, and also increasing our virtual ward capability and our community team capability to look after people at home. Although we've got a 5-day service in effect come Thursday night, the confidence to discharge into the community reduces when you don't have that cover on a weekend. So we've got a case coming to the board in January, which is looking to enhance that cover to 7 days a week. I think the third piece then is we had a conversation this morning around our our configuration and the model we've got, and how we need to take into next year and into our plan how we deliver those services and design those services differently across the health board to make sure we've got a future model for emergency medicine, acute medicine, frailty we touched on earlier. Finally, the final, which I didn't get a chance to reference earlier, is there's a conversation I'm leading at the moment with our Director of Social Care as well around how we develop a really purposeful common intent around what we want to do in the space around prevention, demand management, and pathway of care delays. We're learning from some of the work that's gone on elsewhere in Wales to develop that shared commitment. I think having something that's got that shared common purpose between us enables us to be really deliberate in the decisions we now make, both with the grant monies that have been allocated this year, but also in terms of decisions we make with funding available to us as 4 organisations going into the next financial year as well.
Okay, let's go back to that question of the waiting time for the assessment. So if all goes, and you've outlined a number of things that you're hoping to do, some of them are in train. If all goes to plan, when will that start to feel different for a member of the public?
We would want to start to see that feeling different as we're expanding those services. If we can manage some of the demand into the department, it will make it far easier for the teams we've got to be able to see those individuals on time in a timely way. But there will be some lead-in time in that as well, in terms of how we grow the workforce and recruit and bring staff in to fulfil some of those roles as well. So I think we're probably looking at something that's going to ultimately, there'll be improvements I would want to see from tomorrow, but I think we'll be looking at something that could take 6 to 12 months to really move us forward in the direction we need to move forward and get to where we all want to be. But that doesn't mean not making improvement in the interim as well.
Okay.
I would say our clinicians are driving us towards a systemic solution as opposed to a very local solution.
Okay.
So they are thinking about the health board as a whole and a totality in terms of the provision of these services, and we are very much trying to follow their lead on this process. I think it'll require us to have a lot of courage over the next 12 months to make significant changes to the way in which these services become sustainable in the long term. But I think the quality of them and access to them will be much better as a consequence of those changes once we make them.
Okay. I want to ask about cancer.
It's a question on the urgent emergency.
Yes, of course, yeah.
Yeah, so back in the summer, Jeremy Griffith, Director of Operations, NHS Wales. So back in the summer, I visited the Glangwili site to support you in getting a plan together for winter to be this better for your patients, so they'd have better access to care. You heard aged estate probably mentioned by 4 times by 5 different people today. And he mentioned that care wasn't in the places where he wanted it to be. And there was going to be capital support for it to be better on the Glangwili site, for you to access different clinicians, exactly what the public are saying. That hasn't materialised for this winter. So what capability are you missing in order to deliver those opportunities which we're presenting to you? So it'd be good to get a bit of a feedback, because patients aren't going to get that now this winter in terms of that support.
I think the starting challenge for that in the timeline was the scale of the work we needed to undertake and to the area we were trying to undertake it. So our emergency department configuration is quite tight. I know we went round, one of the conversations we had was the lack of space and the lack of areas around it to immediately add anything on. And so we took a view that the way to increase our capacity was to increase our same-day emergency care facility and footprint. And the work we've gone through is that the advice I've had is it's the timeline it's going to take to do the work we need to do to that area, because the nature of the state to get ready that's the latest beyond this winter. That was very definitely our focus when we had the conversation in the summer, Jeremy.
Okay. So on cancer, Neil, so and we've discussed this in our previous meetings. The number of patients waiting over 62 days is too high, and gynae performance in particular is far too low. So what is the board going to do about that?
Yeah, I'm conscious you've raised this on a number of occasions, and we've been mindful to try and take some action to resolve that. And I think we are resolving that by saying some changes.
No, it's fine. So I think so. No, thank you for the question. I think I think the three key areas we're looking at in terms of our cancer backlog and our cancer performance. So as you rightly point out, one of the areas that we've needed to do some work on and we have taken some action on is around our gynecology diagnostic pathway. Most of our backlog challenges are diagnostic pathway challenge in terms of the single cancer pathway. Our treatment times are very good. When we get to that point, it's getting to the point of diagnosis that's been our challenge. We have launched now across Bangwili and Withybush since the summer one-stop postmenopausal bleeding hysteroscopy service, and that has reduced our average diagnostic time from over 140 days down to under 28 for that particular pathway. So we are now seeing an improved level of time to diagnosis for our gynecology cancers, but also that will start to play through in our performance as well in terms of treatment times. We're doing similar work around the diagnostic pathway for prostate cancer, and we've reduced the diagnostic part of that pathway now from over 60 days to under 30 days as well. And there's similar work we've done around lower GI. Those have been the three areas that have been our bottleneck. We're expecting over the course of the next couple of months our backlog number to significantly reduce. We're at 570 in the last reported figure. The indications are the next month that'll come down to about 540, but I'm expecting over the next couple of months that'll reduce to 300 or below.
And what would be the key drivers of that change?
That will be the increased diagnostic capacity we're putting into really front end the first part of the pathway to get people to diagnose quickly.
Okay.
Yes, if that's all right. So it's Jacqueline Totterell again here. So we always go first for looking to increase capacity, often by extra funding. I'm really curious about what best practice have you looked at in order to actually improve pathways and things like getting it right first time, which we're beginning to adopt in Wales. Where, and it might be more for your medical director. Is your medical director here? No? Okay. You'll do. So, for those who don't know, Phil is the doctor. So I'm just curious that because where we're going over the next few years is actually we're going to have to become more efficient, adopt best practice a lot quicker than we do. We do some fantastic best practice in Wales, but adoption is our Achilles heel. So what I'm really looking for is there's an urgency to get the waiting list down. Then there's a bit about how do you sustain that by being the most efficient and effective you can. And let's take gynecology, because that was the one that the Cabinet Secretary talked about first. What best practice have you adopted when you've really, really looked at what's happening, what's going on, where the inefficiencies are, in order to actually be sustainable in that for women's health?
Right, so Phil Claw, Chief Medical Officer, do we need to give time?
Just the first time.
That's okay, that's checking. So it's a good point about getting it right first time. I think we've learned a lot from getting it right first time over the years. I think our work around orthopaedics has been built around that. So I think we do have a track record of our clinicians connecting with and taking action around the getting it right first time learning. I think with cancer, I think it's a good question as to whether we've got that rooted into all of the cancer sites. I think with gynecology, the work that Andrew is describing with the one-stop clinic is something that we've taken from elsewhere, and I think it's really innovative. And we've implemented it, and there's a difference. In fact, in the past, you'll see that there's a run chart which shows the really significant impact that it's had. So we are really trying to be outward looking, particularly as in our geographical position in Wales. We're trying to adopt and also be very data focused, so we measure the improvement. So I think actually the guy cancer is an interesting one. We may not have seen the full benefit of it yet, because I think we've seen some of the process measures improve. What will be interesting to see is, does that then give us change the target performance?
Okay. Keen to ask on some of the planned care interventions as well, Jeremy.
Yeah, it's good. So planned care, made some really good improvements on planned care this year, particularly the 100 people waiting over 104 weeks and also 52 weeks. The 8 weeks diagnostics is where we made some improvements on. As Jacqueline mentioned there, it's now that's been hand in glove with the national planned care, which the Cabinet Secretary announced on the additional monies. Next year, we need to get into that efficiency and productivity. You've made some benefits and some improvements from that programme. So what does it look, you're in the planning cycle at the moment, what does that look like for next year? And then I've got a secondary question on performance governance then, just on the efficiency and productivity.
Thank you, Jeremy. So in terms of theatre productivity, we have now established the structure we talked about, but as part of that, we've established a new theatre transformation board that's chaired by one of our lead clinicians, and each of the subgroups is chaired by a lead clinician as well. So that's a really clinically driven transformation programme for us. Now we've increased the senior leadership presence and visibility in theatres to support some of that work and really drive some of the improvements. We've got a couple of key, well, 2 or 3, I guess, key pieces of work that we're progressing at the moment in that space. One is a project around aligning surgeon and anaesthetic job plan time so that we address some of the late starts sort of performance issue. There are plans for each of our subspecialties, and coming back to the reference to getting it right first time in the last question, for each of our specialties now in Q4, there is an implementation plan to deliver the GIRFT levels of productivity for each specialty. So they will be being driven through that transformation board. And we've also, through some of our procurement arrangement for some of our medical device suppliers and some of our prosthesis suppliers, we've got some opportunity to access some improvement resource, and the project that they're really focusing on with us, because it's been a bottleneck in our overall efficiency and productivity, is the pre-operative assessment pathway. And so they're doing some work with us to really kind of streamline and improve our pre-op assessment pathway so that we're getting people to surgery really quickly. There are a couple of key risks for us in that space. Our data workforce is fragile, and we've had some challenges, and we're trying to work through both a recruitment effort in that space, but also we're insourcing capacity to help provide additional theatre staff. And we've also got some theatre infrastructure estate issues in terms of maintenance work that we'll have to undertake through the course of next year to air handling units and theatre management systems that will have an impact next year.
Just as follow up that, so you know what the patient benefits from the Get It Right First Time programme. Just in case people didn't know what GIRFT was, I mentioned it. So have you then, if you take this agenda item on improving access and then the first agenda item, do you know what that means for your patients and the experience they get, but also what it means for the financial plan for the organisation in terms of not reliant on, unsustainable sources of income?
So developing our sort of capacity plan for this year, a lot of the work that we've identified in the productivity and efficiency improvement we've built into our delivery plan for the course of this year. So Q4 of our planned care delivery plan very much builds in the efficiency and productivity gains that we're expecting to see from that. And I know working with the finance team and the business partners, we're trying to get much better as well at quantifying the impact of that and how that's playing into the overall value delivery within the health board.
Great, thank you.
So the Cabinet Secretary at the beginning of this talked about taking concerns raised by patients, members of the public, and we also touched on complaints and concerns around the content of ED. But when we look at your complaints data, actually you're performing worse in Wales in terms of response rates. And also you've got just under half of all of Wales is over 1 year waits for a response. So in terms of what your patients are getting, or people who come and use your services are getting, in terms of raising a concern, is that actually quite poor. So I just wondered what your plans are in order to make that better, because getting timely concerns or resolutions to concerns, they don't always have to be written actually. Most complaints are better solved in the moment. I just want to know what the plan is, because that actually needs to get better on behalf of the citizens of your area. Giving you a break.
Great. I'm going to come to Sharon.
Yeah, lovely. Diolch. Thank you very much. I'm Sharon Daniel. I'm the Director of Nursing Quality and Patient Experience. Thank you for the question. In terms of, you're correct, Jacqueline, in terms of the number of complaints, especially complaints over 12 months, we did have the highest number of complaints open at a point in time. And I think that was due in part to capacity within the team, to absences, but also we had a significant organisational change, and therefore we were embedding a new management process within the organisation. In terms of the action that we've taken, the capacity now within the team is back to where it was, and we have some really good staff that have coming to work in that area, and we're also working with the clinical care group leads as well, in terms of the quality and the timeliness of the complaint responses, etc. The medical director and I also now meet with the clinical leads within the CCGs. We have fortnightly meetings put in so that we can meet with the ones who are have the longest.
CCGs are clinical care groups.
Clinical care groups, yeah, exactly. But also at the same time, we're working on the new regulations in terms of putting things right, that are coming into play in April of next year. And as you say, to ensure that we can fulfil those requirements, there's going to be a big change in the way that we manage complaints. And coming back to what you were saying there, it's around listening and speaking to individuals and focusing on early resolution and addressing concerns before they get into that complaint process. So, sorry, in terms of our performance at the moment, we've now at the moment got 10 complaints that are open over that 120 days, and the trajectory is to close those by the end of this month.
That was my closing question. Thank you. Okay, we're going to move on now to the third agenda item, which is about what the board is doing to get services ready for the future. I'm conscious that we're running a little bit behind, but it's been important to cover the discussion that we have. But I'd be grateful if we could all bear that in mind in the duration of responses and statements. So, okay, great.
Okay, President.
Diolch, ysgrifennydd y Cabinet. Thank you, Cabinet Secretary. So, look, we do face many challenges meeting current demand and need. And we know that the demographic predictions will mean this will only get more challenging. So when we look to the future and what our service model should look like, it needs to be different and radically different, we think. And it's not going to be just about increasing effort. We are refreshing our strategy. We agreed a health board strategy back in November 2018, and that was following large engagement and consultation. But 7 years have elapsed. We've had COVID. There's all sorts of learning over those intervening years, and we're going to bring that to board. And we've been in January, but we've been listening to our public and our staff as we create that. We will continue to be underpinned by a move to a more social model of health and wellbeing. It's important to us. And we've developed, as you've heard, the 24/7 model, which was developed by our public health team and our public health. The 20 is the 20% of practices where we see the most economically disadvantaged populations. The 4 is the 4 healthy, unhealthy life behaviours, so alcohol, smoking, physical activity and nutrition. And the 7 are the areas of burden which cause the greatest burden of disease, which is amenable to another part, so things like cardiovascular, respiratory, mental health. We have 7 in the pack. So the key part, 2 of the really key parts of our strategy, which we will really emphasise, is how we build community and primary care capability and capacity. And secondly, how we harness digital AI and tech. And we think we're already on a road that, that is going to be a key part of the strategy. We're also, we're already implementing important systems like our flow system just went live. That's going to help us really significantly around our ability to operate that either urgent emergency care system, virtual wards. All of that is made much easier with this flow system. And we're getting better at data use. We've got a number of dashboards which we put together. We've got a performance dashboard, a productivity dashboard, but also a safety dashboard, which has been developed by our clinical executives. It's really key to us. And we're developing a population health one and even a culture dashboard for our organisations, which we can sort of talk about. So we've got significant service, workforce and estate challenges and vulnerabilities. And we've been working on our clinical services plan. It's clinically led and consulted on that. We'll be bringing that back to board. We're in a period of conscientious consideration at the moment. We'll be bringing that back to board in February to our public board for decisions, and we'll be listening very carefully to what the public have said. But our clinicians are key to this and leading it. But those aren't the only 9 services that need addressing. There are others that are fragile that we know we need to work on in the coming year. Years. The programmes in the pack, I won't go through them all, of course, but those we believe, like women's health, maternity, mental health, university, quality of governance, key to understanding of this, we believe will all help us move towards our strategy. I think in relation to population health, we're really proud of some of the progress we're making in that area. So smoking cessation, we're ahead of Wales in quit rates. We've seen an increase in numbers being referred to quit from our hospital by 93%. We're seeing quitters in community increase, which is different to other areas. We've also seen the diabetes prevention programme have a big effect on the people who we're able to get to. We've seen reduction, actually, people who don't have hypoglycemia after going through that programme, I think 41%. And also our immunisation vaccination programme has made progress this year. In the 4 to 10-year-olds, we are ahead of Wales in that list of 56% versus 43% sort of nationally. So there are some areas where we've made some real progress this year. So I suppose just to close, I think the direction for us is becoming much clearer, and we're much clearer about the challenges that we face. I do think we've made some progress this year in this regard, but there's some significant challenges we're going to have to get over to reach where we need to be. I'll go there.
Thank you for that. So I've had a lot of correspondence over the last 6 months in relation to planned or proposed service changes. So primary care, MIU, stroke services are examples of that, which you will not be surprised to hear, obviously. What I'm interested in is this. So take stroke at bronchitis, for example. There's been a particular campaign, and the theme of the campaign has been there needs to be a different kind of way of looking at hospitals that serve, rural areas and serve a large hinterland. And has the board looked fully at things like telemedicine and those sorts of. So I don't have a view on that. It's a clinical argument, but the question I have is this: what are you doing as a board to persuade the local population that the judgments that you're considering and that you'll be making next year are clinically driven, are clinically led, so that they can be confident that even choices which are going to be unpopular are ones which ultimately are being driven by clinical priority and clinical need?
I start. We appreciate the clinical service plan is contentious. Not all of it, but there are elements, including stroke services, which are highly contentious, very site-based. If we think of it as a service, it's suboptimal. It's not delivering to the standard that we would want to deliver. It's a fragile service. If we think of it from a community perspective, actually, they value that service, even if it's struggling or it's not delivering everything they need, they value the service. I think the challenge for us has been how do we create that narrative with the community that says, actually, it is in the long-term interest of patients for us to recalibrate how this service is delivered and where. No, I think Cabinet Secretary, where we've managed to get into a room and sit down with people and have that conversation, and we've consulted extensively across across the patch, then people see the sense of that, and they think of balancing distance against potentially the quality of the service, and they understand what they're looking for, and what they're looking for is a quality service. So I think once we are engaged in that conversation, then often what we find is that people are supportive of it. What they do identify is the challenge of transportation and travel. And of those things, we need to be deeply mindful, because there's a fundamental inequality built into that process if people can't get to the right location or the right site. So I've always said in those conversations that we have a responsibility to address those issues, as well as just think about the clinical direction of travel. Now, our clinicians are absolutely wedded to the idea that these services need to be different in order to improve the quality of them, and services that they feel they can be proud of in their delivery. What we're trying to do is blend with that clinical imperative, a community voice, and try and find a way between that, navigate a way between that. Do I think that we will make everybody happy as a consequence of this? No, I don't. Do I still think we need to be brave in this space? I do, for long-term services being developed and for their sustainability.
So what does the transport element of that look like? If you have obviously rightly identified that as a concern, what's the board thinking around that?
I'm going to bring Lee in here, because what we've done is because it's obviously not an area of our expertise. We are not.
No, I'm asking an open question, really. I mean, I just want to hear what your thoughts are.
What we're trying to do is embrace the idea of transportation as a potential solution to ensuring that people at least have some level of assurance that they won't experience a greater degree of inequality or disadvantage as a consequence of relocating these services.
Yeah, thank you. So I'm Lido, the Director of Strategy and Planning in the Health Board. So just to pick up on the first question initially, and then I'll get on to transport. So we have, and as has been mentioned, we have had the clinicians leading the discussion around the options. So the options that have been developed for the clinical services plan have come through an options development group, which was it included all of the clinicians for the relevant services and operational leads. We weren't part of that. We received that information and that assessment. And when we've had our public events, and we've had lots of them, over 4,000 people have been engaged through those conversations. Our clinicians have been there having that discussion. And what as Neil rightly describes, what we tend to find is naturally people have concerns. That's understandable. As we get into the conversation and expose the dilemmas that we've got around some of the realities of trade-offs between the highest quality clinical care and the consequences of that for outcomes versus the dilemmas of rurality and geography, people recognise that that's not a simple decision to make. And in reality, that's the reason why we're in the situation we're in. It's because if it was straightforward, we would have already made that change already. So I think that process itself has been very helpful in having that dialogue. And as Neil said, we've been very open to speak to all groups and community representatives to support that. And what we've seen with, if you take, say, the minor injury unit in Prince Philip, when we engage with those local groups, and SOSPA, the local group there were very constructive in their engagement with us. We get to solutions which blend, as Neil says, that the clinical imperatives with the community voice, and we get to solutions which hopefully will turn out to be the right decision. Now, of course, we don't know that fully until it happens, but we've been flexible and accommodating of different views, and that's influenced our thinking. And so we're clear in the process so far that we have not made any decisions. We're open to people's views and ideas, and they will influence our thinking and influence the ultimate decision, no doubt. On the transport points, there's a couple of components to that. There's a transfer of patients between sites. So we've got a work that we've done with WAST and others to look at what the transfer model could look like, because we need to. We recognise that the WAST service, the core WAST service, will not be sufficient to allow that to happen. So we need to supplement that, and that's been part of the planning and discussion with WAST. And then the second issue is around transport. So there's various components to that, but we obviously work with partner organisations, the councils to look at the opportunities to improve that. We meet regularly with Transport for Wales to look at things like bus schedules and practical questions around how you can change the issues. And then we're also looking at alternative ways of supporting members of the community to access health services through community and social support mechanisms outside of, say, buses and trains and so on.
And are you planning to find a transport solution as part of the service change? As in, do you expect to solve the transport challenge, before or at the same time as you make the service change?
I expect we'll have solved the transfer of patients. We'll have to do that in order to change. I think the transport challenges of West Wales would be beyond us to solve.
I don't mean they're entirely in your gift. I do understand they're not. But if you're planning a change,
yeah,
and we've identified already that one of the things that people will look to in order to feel for themselves whether this is a change they think is an acceptable change is the ability to get to and from places. I know you can't deliver necessarily the solution, but what's your thinking about there needing to be a solution before people are going to accept the change?
I think there are aspects that we'll be able to introduce before we deliver the change, but I think this is a long-term challenge that we're going to have to face collectively with our partners.
Okay.
But we have said, Cabinet Secretary, we will not make a change that introduces an additional social disadvantage in the process. So we will do everything we can to make sure that is introduced that causes an inequality in the process.
Okay.
Sure, if I just come in.
Thank you.
I'm going to bring Isabel then.
Oh, I'm so sorry.
That's okay, thank you. So first of all, congratulations on the meaningful consultation on your clinical services plan and the progress on your public health programs. I was wondering if you are bringing in clinical expertise from primary care into the development of the clinical services plan and also public health expertise to ensure that integration of services and that increase in the delivery of integrated services in the community. Particularly, I wasn't sure how your clinical services plan and your strategic plan for primary care come together and ensure that integrated provision closer to people's homes, and how the changes that you are making therefore will help us ensure the sustainability of both primary and secondary care services.
Very good question. because I think I do think we struggle, with having a bit too much strategy on the landscape and then wondering how they connect together. So I think that's a really good question, Isabel, in terms of the primary care, because we have tended to think of it as a secondary care innovation or change, but the consequences for primary care are considerable as well, as you quite rightly point out.
So yeah, it's a good question.
What's the answer?
So the first thing to say is that the clinical services plan is 9 services that we agreed as a board 2 years ago that are fragile and we need to address those fragilities and improve quality and access for patients. So that's why we put together those 9 services. But as you're saying, Isabel, it isn't a comprehensive clinical services plan. And in fact, what we learned from when we consulted on the Transforming Clinical Services Programme 7 years ago was that actually that's the clinical elements of it. We're actually a health board, and a lot of what primary care and public health do isn't just about obviously healthcare, and healthcare only contributes to 15% of health and well-being. So I suppose what we're trying to do to address the question you're asking is through that 24/7 approach, through those seven areas which are really significant, which our public health team put together. I know that our public health director is working with colleagues from primary care and colleagues from our hospitals to work out how to approach that in a different way across the pathway. So at the moment, I know, for example, cardiovascular disease, she met with the cardiologist, primary care and her team to look at that pathway just this week, for example. So I suppose some of it will be from the 24/7 approach, there will be a pathway by pathway approach. However, taking a step back, on some of the major, more strategic programs like the Community by Design. I think we've got, I think what we're finding is that we've got some really strong primary care voices, some really strong primary care leaders leading our clusters, but we probably haven't engaged sufficiently in the totality of the strategy. So when we look at some of the UEC work that some of your ideas around bringing them to integrate it to support us with that UEC work, I really don't think we've maximised their voice. I think we've probably only got 20% of it. So we know that that's a challenge for us going forward.
So how do you plan to bring this together to advance the national ambition to deliver integrated services in the community, the Community by Design program?
Yeah. So, and as you know, I'm leading one of the pillars, the urgent same-day access pillar. The population health pillar for us, it will be as described. It will be our 24/7 approach, and which links very much into the national process. For the urgent and same-day care, it is the, I know you may want to come in on this, it is the fact that we're bringing our primary care needs together structurally with our hospital needs. So I do think we've got an approach that will help with that. So I'll come to you on that. I know that and the same would go for the chronic conditions, which fits, I suppose, those burden of disease areas in 24/7. So I do think we've got an approach. I
So
think
some of these have some of your fragile services, relate to your fragile services. So that's why I think it would, you might want to consider how it all fits together as you continue to develop the clinical services.
So the bit for me with this is we talk about the things that are happening in a place, a building. But what we're grappling with, so this isn't therefore you've not done it. It's difficult grappling area. Is how do you do the things that are right in the place and the building versus actually implementing pathways that actually start with prevention and end up back in the community? And that's the bit about how, beginning to try and understand. So diabetes is a classic. Why we don't have our CNS diabetic nurses that work in the hospital working across the pathway is interesting. So I think that's where I think we're trying to go, is how do we actually really tie this together so that the place is solid, but the pathway is clear?
I think our 24/7 approach gives us a chance of that, because diabetes is one of those areas, respiratory, cardiac, of which I agree that the pathway is hospital centric. I mean, it comes back and actually it's over medicalized in many ways, because if you're looking at the diabetes prevention program, our challenge with that isn't its effectiveness, it's that we struggle to scale it. Because it's very effective. So I think part of the excitement for me is that we've seen some benefit, some significant benefit there. And how do we then scale that up? I think that's why my point about having the cardiologists, the public health team and the primary care team looking at those pathways, I think we will get the right answer from them as long as we bring them together and facilitate it. The other point last point I make on it is that in some of our practices, they are seeing 12,000 people a month, 12,000 interactions a month. When I talk to our primary care leads about how many A&E attendances we have, which is about 126,000, they're shocked at how little that is in their mind compared to the amount that they would see in primary care. So there's clearly a huge amount of learning and benefit that we can get from their expertise, because in their minds they think, well, surely we could have an impact in modulating that demand if we got the conversation right.
I know that James wants to come in, but I know Andrew, you want to say something briefly?
Just very briefly, because I think a couple of things. So I think just to say, so for some specialties like diabetes and we've got our specialist nurses are managed in the community by Iechyd Nursing for Chronic Conditions Management. So we have kind of relocated them, if you like, systemically into a different part of the system. The cluster piece that I really want to do is to work out how it is to bring them into our integrated systems and use them as the organising principle behind how we organise and coordinate our community service model, but also then plan and deliver services across across the health board and pull in that whole pathway kind of conversation. And that's a conversation I'm working through with Mark as the medical director as well, in terms of how we bring together our medical leaders across the organisation to facilitate some of those whole pathway conversations using some of the principles of value-based healthcare that we talked about earlier on. So I think there's some tangible actions in that space.
Thank you.
Yeah, so I apologise, Lee. I want to come back to this transport issue because I do think it's very key, and it is, I think, very important for public confidence in the service reconfigurations you're undertaking, because there obviously has to be an element of risk management. Some medical care needs to occur urgently, so stroke, myocardial infarction, and because of the service fragility you described and things, you will be needing to probably downgrade the ability of some of your sites to manage acute care and reinforce the ability to manage that care to a high quality elsewhere. So I would argue that transport actually becomes part of the clinical pathway. It's not a separate thing. And I think that's what you were saying, but because it's so important, I just want to clarify that you are considering what special provision will be required to transfer people in a safe and timely manner for the time critical pathways that you're redesigning. Yeah, because the standard WAC service, I don't think will be able to provide that.
That's absolutely right. So firstly on stroke as an example, one aspect we've been keen to communicate to the public is that we're describing a treat and transfer model. Yeah. Anyway, so wherever patients currently access the initial treatment for stroke, they will continue to receive that, irrespective of what change we make. There is then obviously a necessary transfer of the patients from those sites to whichever site we decide to provide stroke from. And that will be an additional requirement, as you rightly say. So that's why I was trying to distinguish between the transfer of patients and transport more generally. One point I would just add on transport more generally as well is part of what we find in our engagement with the public is sometimes there's a lack of knowledge and awareness of the various support that exists out there for patients and visitors needing to access sites. So part of what we're looking at is how we make it easier for people to access those services and points of contact, so there's clear who you contact if you need some of that support.
Yeah.
Very briefly, if possible. Sometimes when you transfer patients in the way that you've described, that can result in increased length of stay. We've touched on this earlier. How are you considering how to make sure that this does not result in beds being occupied more than necessary?
So, I mean, one of the things I did want to say was that our change is about enhancing equity. So one of the worries I have at the moment is that when you look at stroke, none of our services meet standards, not one of the 4 units that we have. And so that means that none of our public have access to an equitable access to a standards-based service that you would get in another area. So that's the whole rationale for the change. I suppose the points about securing, making sure we're confident that they can get to that equitable service then become important. So I do believe it's all part of the same model. In terms of the length of stay, that's a challenge for us across the geography, because whenever we move a patient from a site, but even between our health board, it can introduce challenges in getting people back. So our repatriation service, I think, has got to be a lot better than it currently is. We know that.
Can I just add one quick point? Yeah. So obviously, what we're not prescribing is that we reduce the number of private sites providing a service and not enhance the service, as Phil says. So in the case of stroke, for example, we know that if we have the right therapy services wrapped around that provision, plus obviously the stroke consultant provision, that reduces length of stay, improves outcomes, and so on. So this is an enabler to actually get to that position. Now, I appreciate obviously transferring patients does add a risk to that and a complexity to that, but that's the full package, I guess, that we're trying to look at.
Okay, thank you very much for that. The last of the 4 items that we're covering today relates to how we are strengthening how we run the NHS, and on the rest of today's discussion, how the health board is running functioning and operations.
Fernando,
from Capital Independent Fund. As a health board, we've been focusing on how we stabilise and develop our workforce, support people to be their best in work, and how we attract people to fill our vacancies. We have a People, OD and Culture Committee that meets quarterly to oversee our action linked to these broad goals. Our organizational development team work closely with our staff and managers to drive cultural progression within our authority. This work incorporates staff discussions, local culture surveys, and compares outcomes and themes included in the National Staff Survey and engagement with our Speaking Up platform. In addition, we analyze what we hear from places and stay interviews, and by trying and implementing this, we support services to develop our people culture plans. Workforce planning and effectiveness are key to reducing reliance on the agency, and we've already heard about how we've done that, and to provide a workforce for the future to meet our clinical services plan. We're working through some of the challenges for all options being considered as part of the clinical services plan, and how we would plan to mitigate these by different ways of working, new roles, and further training opportunities. Equality and diversity is a key focus for the board, and with the establishment of an equality task force, we will be driving those improvements in how staff are supported and developed to ensure we deliver on all aspects of our action plans. Through regular reporting to our committee, we ensure we have oversight of key workforce metrics. We review workforce growth, changes in turnover, sickness absence, agency usage, as well as appraisal and core skills compliance. To ensure we understand how our workforce feel, we ensure we regularly hear from people in the committee. These have varied from an internationally educated nurse around her experience joining the health board, and myself personally, I've worked with most of our internationally educated recruitments. And to someone who has been involved in an employment relations matter, an armed forces veteran, and a nursing team experiencing simulation training. To further drive a reduction in sickness absence, we have also developed a tool to consider our workforce health alongside population health information. I'm sure Lisa will be able to explain this tool a little bit more than I can. Cabinet Secretary, despite the above and information in our evidence pack, we recognise that our staff still face challenges in delivering our services, whether this is linked to workload pressures experienced as part of our control mechanisms and or daily staffing challenges. We do work closely with our trade union colleagues and hold regular meetings with our union leads to discuss any key issues and to focus on ways we can work together to make improvements. To strengthen everything I have mentioned, we have introduced a comprehensive suite of leadership development programs to support all of our leaders, regardless of where they are in their career. And I'm sure Lisa will be able to give a little bit more details in terms of the questions that you may have.
Okay, thank you very much, Chantal. Actually, I'm going to pass to Hywel about agency.
Okay, the cover section. So your forecast is to deliver a £700 million improvement in local emergency spend this year, which is obviously positive and will exceed the 30% reduction target set by the Cabinet Secretary in the enabling actions. Yes, my observation would be that that improvement is largely exclusively in the registered nursing workforce, which is incredibly positive in that area. But I think it leads to two questions. One is, what actions can you take to then maintain that progress? And then secondly, what about addressing the challenges in other staff groups? Yes.
Thank you very much for the question. So I'm Lisa Gostin, I'm the Director of Workforce and OD and the Deputy Chief Exec. So the first one then around how do we maintain the action. So our nurse stabilisation programme has actually been in place for a couple of years now. We approach it in three areas. So one is around the recruitment. The second then is about how we retain individuals, and the third is around how we develop. So as one element takes effect and leaves, the next one comes in. So the nurse stabilisation programme, we're now down to 70 whole-time equivalents. We were at 200 a year ago. We know those 70 are in theatres, ITU and emergency departments. So we know around the pressures as to where we have them, and we have got plans that we're putting in place now in those three areas to further reduce the agency and hopefully move next year to an eradication of agency. That's certainly where we would want to be. And we've recently gone out to advert for
post in RED, and we have got candidates who are coming forward. How we can then move it to other staff groups. So medical and dental is the second group that we've moved to. We're starting from a very different baseline with our medical workforce. So when we started the programme with nursing, we had rostering. It's been in place for a long time. We knew exactly what we used, where we used it and why. We've introduced the medical bank in January of this year. So we now know every single shift that is coming through that needs to be booked. So we're getting that intelligence about why. The rostering has been rolled out into 5 places. We will achieve full rollout by the end of March next year. So once we have that, we will then have a good set of data in terms of exactly what we use, where we use it and why we use it. We will then start with the implementation plans similar to nursing around how do we drive the specifics for each of those service areas. So at the moment, what we're doing is a very generic approach around recruitment, so targeting for substantive appointments. And we're averaging about 1 appointment every fortnight at the moment for consultants, so 22 so far this year. We are then looking at the locums that we have, how many have got specialist registration and how many can we look to appoint into substantive posts, and we've started to do that. And we've then got our grow your own pathway for the medical workforce around supporting those individuals that want to become consultants, so that they can be appointed once they have their specialist registration. We have a turnover group for medical workforce as well to understand what will keep the medical workforce once we've appointed them. And the same for allied health professionals. Now, allied health professionals, the majority of our agency use there is supporting our waiting list activities. And we're working very closely around a workforce plan for that staff group. So we're using a similar methodology, but starting in different places for each.
I was interested in hearing what the board's assessment is of the relationship or connection between workforce challenges on the one hand and questions to do with overall performance on the other, in planned care, for example, and questions of patient safety. What's the board's assessment of that?
I mean, so it's been indicated we would use Quality and Safety Patient Experience Committee to very much measure and monitor patient experience, including safety and the quality of services. Whereas we use our People and Culture Committee largely to focus on the workforce, although increasingly there's a crossover between those two things. As I think we sophisticate our process of workforce planning, so I think we're much more conscious of trying to operate less in the moment and more about what do we need in the future, partly as Lisa's indicated. I do think, Cabinet Secretary, we tend to, when we see some of those challenges around the safety of services or the fragility of those services, we can usually go to source and find a connection with the workforce, either capability or capacity. And I think we are becoming much more conscious and aware of that and mindful. I think our challenge is to translate that into a sustainable workforce plan for all of us clinical groups.
So we've formalised our assessment of fragile services. So Sharon may want to say we have a fragile services framework because we've recognised that the interconnection of those things. I don't know whether Sharon just wants to highlight that.
Yeah, thank you. Just to say, we developed the framework aligned to the risk register, but also the criteria that designate a fragility within a service. And our clinical care groups are now working through all their services to conduct an assessment in terms of which services are fragile and which ones are most fragile. And we've introduced an escalation process whereby some of them are managed within the service group, some of them within the clinical care group, and then some would need to be escalated up to the executive team and then to the board. So that will give us foresight in terms of what services are fragile and what we need to be doing about that. And I guess in terms of the question around how we get assurance of patient safety in relation to our workforce, Finn's already talked about the through the quality management system lens, the quality planning, but the quality controls as well in terms of the governance that we put around our systems in terms of protocols that will help our clinicians to make those clinical judgments and professional judgments while they're in the workplace. And then
sorry, I'll just interrupt you for a second. How do you evaluate if that's working?
So in terms of assurance, then what we have the quality dashboards that we've talked about, that we've developed recently. Who mentioned the performance dashboard and our safety dashboard, and our safety dashboard has specific incidents, key performance indicators, including incidents, complaints, patient experience, but also clinical indicators like unexpected admissions to ITU or cardiac arrest within the system, or deconditioning. So we're introducing the DERI tool, which is NHS innovation tool, as an early predictor of deconditioning within our system. And then we have a quality safety intelligence group that scrutinises that data with the clinical execs, and then we feed that up into the executive team.
But how do you link that to workforce questions?
I suspect it's around how we enable and empower our workforce to make those decisions and to manage the risk across the system, and how we can develop the workforce, medical workforce, but also how the clinical workforce like nursing or AHPs in terms of enhanced advanced consultant level practice, how we develop that going forward to supplement the medical workforce that we have. Yeah.
James and then Isabel.
Yeah, so James Calvert, DCMO. So it is obvious from the pack that you're investing a lot in staff, presumably as a result of your retention programme. And I was impressed by the work that you've done on the culture dashboard. That's quite impressive. I haven't seen that before, and it's good information. But your own staff survey in 2024-25 showed that staff felt unsafe reporting errors and felt that those who did report errors were treated adversely. So I didn't quite understand how those two things tied together. So how have you analysed that element of the staff survey, and what are you doing about it?
Sure. So I suppose, like many things, there are things we're making progress on, but we know we've got a huge amount to do. And you know, as leaders, we know that's a big impact on culture leadership. So we feel very responsible for that. It's why we're paying so much attention to it. Why we pay a lot of attention to our staff survey. So clearly, I don't know, Lisa, maybe if I hand over to you.
Yeah, thank you. Thank you for the question. They're very much linked. So the reflective progression work. So people culture plans, we engage with our services, with our managers and with our staff. And we have conversations with them around 7 domains of the plan, and that was in the pack. The information that we take into those conversations includes the information that we've had from the staff survey results as well. And we also undertake a monthly survey amongst 1,000 of our staff. So the view is that by the end of the year, we'll have surveyed every member of staff. And that information goes in as well. So we triangulate the information from all three and then develop the plan for that particular service based upon what people have told us. So there are certain things that we're seeing in that plan that are exactly the same in each of those surveys. So every service will have its own specific plan around that. We've also then got a health board-wide plan with our trade union reps around some of the key things that came out of the staff survey. So we've got a more generic approach to how we look into those issues and manage what people are telling us.
Thank you, Lisa. Just in relation to patient safety, when we looked at the staff survey findings from last year, we picked it up in the Quality Safety Experience Committee, because although there's been a slight improvement from the previous year, it still wasn't where we would have wanted it to be. The committee discussion in relation to patient safety specifically was around ensuring that our staff felt safe to report incidents, that we reviewed our trigger lists, that we fed back to staff the outcome of the investigations following reporting incidents, and just to, with the focus on developing that psychological safety and empowerment really. And then we also focus on staff morale as well as part of the action. And the third one then was just nurturing that healthy working environment as well, so so that we can protect staff from difficult decisions within the environment. Yeah.
Okay, thank you. Isabel.
Thank you. So I was wondering to what degree the workforce availability issues, particularly senior clinical roles, are having or not an impact on pressure, motivation, sort of burnout, of feedback. And also you talked about the importance of looking forward and workforce planning. So to what degree are you embedding that in your plans for the future, and thinking about how can you develop roles in your new structures that are attractive to clinicians, including perhaps opportunities for research or other things that might create interesting roles for the future?
I'll start. I suppose. Well, I think the answer is that the gaps in some of the medical workforce do have an impact on performance, and we do worry about the impact on quality and safety. And in fact, our emergency departments, as we were talking earlier, we spent an hour with our clinicians earlier about that very issue. And part of it is we are running 4 hospitals across a geography, and we understand why all of those services are much loved by everybody in those communities, and the worries about transport. But when you run 4 medical, takes 3 A&Es, 3 trauma, so that we can't simply triplicate and quadruplicate the amount of medical staff that are in other health boards, for example, or in England. It's quite an unusual situation we find ourselves in, but it means that we're very creative in the way our staff operate, in the way our staff work together, and in the kind of roles our other professions, apart from the doctors, take on. And we've been used to being like that, but unfortunately that's necessary but not sufficient for the future. And it's why we are going to have to relook at that model, because we think, and our clinicians are telling us very strongly, that by perpetuating the model that we have, it means it's less attractive to people to come and work here or stay working here, actually. And it means that we just cannot provide the equitable kind of care that we really want to. So we are. I think we are creative and innovative. I think on the research and innovation question, in the last 7 years, we have significantly increased our research and innovation capability and capacity. We've got much more research active clinicians compared to other sort of health systems of the same size. We've upped the trend, I would say. We've also set up TriTech, which is a collaboration of clinical engineering, our research and innovation team, and our clinicians in collaboration with 2 university partners, where we're able to test out safely innovations from industry. We can connect with industry in a way that we could have never have done before, and actually the NHS finds quite hard to do now. And I know across Wales that people are interested in that because that's something really innovative, I would say. And we've set up the Centre for Social Innovation with another university partner to really try and push forward the thinking around a move to a more social model of health and well-being. But there is a real, so we are trying to create these really interesting opportunities for clinicians, and I mean in the broad sense of clinicians, and in fact any staff to come and work with us, because I think we've got some exciting challenges to grapple with, but that doesn't take away from how difficult some of them are.
Can I I think it's a very good question, Isabel, because it feels to me as if the health board's been quite tolerant of its clinicians not being happy for quite a long period of time, and it kind of thinks, well, that's just the way it is. And I think increasingly we've become intolerant of of the fact that actually it's not a good, often not a good work experience for our clinicians, which then creates a vicious circle. Nobody wants to come and work for us. Nobody thinks it's the right opportunity. We don't train or develop staff appropriately. So I think that's absolutely a focus. I don't think we can be sustainable unless we address those issues. And I think that will be a focus for us in the future.
Yeah, thank you. We've reached the end of our 4 agenda items. For those watching, just to reiterate, necessarily the focus is on areas which have been challenging as opposed to areas where there's been particular success. So if there's anything which you feel you haven't yet had an opportunity in any other part of the agenda to put on our radar, there's a couple of minutes for you to do that now before I sum up.
Thank you. Thank you very much, Madam Secretary. That's all. Say a few words then. I might want to add to that. I think we've probably articulated quite a lot of where our challenges lie. I think there are dynamics to the rural environment that we're finding it increasingly difficult to deliver. And the more we try to grip the importance of quality and safety, the more we realise how challenging that rural environment is towards delivering that. I think you asked a very pertinent question in terms of how do we bring community with us to deliver some of these radical, frankly, uncomfortable changes in the future. And I think, I very much think that's the focus of our energy and our communication with communities. We're trying not to work with communities where we present them with a choice of blue or green. We're trying to work with communities to get them to understand what good health, happiness and welfare looks like, and how we're a contributing partner to that equation. So I absolutely believe those are the issues that we're facing. And we talk about, well, if we had lots more money, would we not build all these services in these environments? Well, I'm not convinced that's the good solution either. I think there's something about, we were challenged earlier in the year, Phil and I, when we went to Aberystwyth in January. The challenge was, well, we're just trying to save money in terms of rethinking our stroke services in Aberystwyth. And my response was, no, we're not. We're trying to make sure we spend our money well. We're trying to make sure it delivers the best possible value and impact. And I think that's what we've got to continue to strive for with your support. Thank you.
Yeah, I suppose that there are many things you've heard that we're proud of, that we're making progress on, whether it be the reduction in temporary staff, that supported our financial improvement, the cancer performance, the planned care performance, some early improvements around urgent emergency care. I suppose all of those things will affect real people in our communities, and we're really proud of what our staff have achieved in that. And also, we're really pleased to see the way our clinicians are coming forward to lead some of the service change we're seeing around the clinical services plan. And also some of the public health work that we've highlighted. And we haven't mentioned the work we're doing in partnership as much today with Swansea Bay and also through the Mid Wales Joint Committee, which I think is significant, those sort of collaborations that we have. And we did have, I think, a very positive structured assessment from Welsh Audit Office, where we had 2 very small recommendations for us, which I think is a real positive in the way we're governed, or we govern ourselves. But there are these significant challenges, as we've described. You know, some of it is around how we do shift left, or we shift into public health. We've talked about that today. Goodness me, that, you know, that occupies a huge amount of our thought, how we allocate resource towards that. I think also our immediate challenge around urgent and emergency care, your challenge around, or the public's challenge, frankly, around the clinical assessment and availability of ambulances, all of that. We know we've got that immediate challenge, and hopefully we're giving some assurance of the approach we're taking to try to address that challenge. But some of it is about the sustainability of our system and the way we operate, and that shows through in the service models, the workforce satisfaction, and also the reliability of the patient experience that people get in our services. And some of it is about state that we have, that we will need help with. But look, hopefully it's given you a good sense of where we're proud, but I suppose we're humble about our progress, because we know there's a huge amount more to do.
Diolch yn fawr. Well, thank you everybody for your time today for the discussion. The three things that I wanted to say in conclusion, and we've discussed a range of important issues, so this isn't to detract from the breadth of that discussion, but the imperative of continuing the work that you're doing to get that trajectory to balance over 3 years, and there will be difficult decisions to be made along the way, but that's absolutely imperative. And then, Phil, as you were saying in your closing remarks there, that focus on improving the experience for urgent and emergency care, reflecting the public's priority there, and getting to grips with the cancer backlog. Andrew, you spoke earlier about some of the interventions that you already have underway, but those three areas are absolutely critical for us all. Diolch yn fawr iawn.
Yeah.